Okay, so I think we're going to get started. It's my really great pleasure today to have with us Dr. Rony Avritscher for departmental grand rounds. I've known Rony for nearly 20 years. Basically, I was a fellow at MD Anderson at the same time that Rony was a fellow at UT Houston. And then we both basically just stayed on, and I was his attending, later mentor, later colleague at MD Anderson, and also really good friends. So I'm really honored to have him here today. From an academic standpoint, Rony is now very clinically active in the Society of Interventional Oncology, RSNA, et cetera. He's very, very well known in interventional oncology, but now he's really focused a lot of his academic career on immunotherapy, and he's actually been considered one of the key opinion leaders in the field of immunotherapy, especially as it relates to IR procedures. In terms of just academic background, Rony's had about 40 peer-reviewed articles. That being said, some of them are his first author and or senior author on ones that are in high impact journals such as Radiology, Magnetic Resonance Imaging, and Clinical Cancer Research. So it's really impressive that a lot of the work that he's been doing, especially in the area of immuno-oncology, that's been really in top flight journals. He's also had a number of awards. He won the JVIR, basically the best laboratory research paper in 2014, and was recently inducted into the fellowship of Society of Interventional Oncology. So in terms of today's lecture, as you all know, immunotherapy and immuno-oncology are one of the top areas of interest in all of clinical medicine and research. And Yale, as you know, is one of the leaders in this field. So we asked him today to speak on a topic that I think will be very, very important for diagnostic radiology as well as interventional radiology, which is on imaging of immunotherapy. So without further ado, I'd like to welcome Rony. Thank you.
Thank you, David, for the wonderful introduction. It's really an honor for me to be here, and I hope I can, in the next several minutes, I can share with you some of my research and some of my experience in the field of immunotherapy, especially as it applies to radiology. And the lecture is divided in three. So when I started being more interested in the particular concepts of immunology in treatment of liver cancer, as a radiologist, like the rest of you, I had very little background in immunology, so I had to go back and study immunology and try to, acquire some of those concepts. So what I thought it would be useful, for this lecture is to condense all what I thought was the most useful, most impactful information that I've acquired studying, and give it in a something you can digest in a few minutes, and then you'll know more about the backgrounds of the immunotherapy than you'll ever need. So I thought, try to be as helpful as possible for the audience in terms of saving some of your time. The reality is that our body is constantly eliminating these tumors. So we have, these mutated cells, transformed cells that circulate, and we effectively, and this is a concept that's been around for nearly 100 years, our body is surveilling for those cells and is very effective in identifying some of these antigens, expressed by these cells. And there's different mechanisms, both innate and adaptive, that it uses to recognize those cells. And through a combination of cytokines and other agents, it gets rid of these cells, and you end up with this desirable effect, which is the most common situation, and the tumor is eliminated before it actually becomes a tumor. Now, the problem is that obviously that doesn't always happen. And why it doesn't happen? It doesn't happen because over time, there are mechanisms that these tumors develop that either mask, so they evade, or they resist the body's innate ability to eliminate them. So some of the things that happen from one point to the other are the loss of these antigens and also the recruitment of certain cells toward that environment that suppress the body's ability to fight the tumor. So we'll go that into a lot more detail in a second, but I think it's a key concept, which is these cells are always there, they're always being eliminated, but for very specific reasons, some of these tumors are able to evade our body's immune system. And unfortunately, if allowed to proceed, you have further loss of the body's ability to detect it, and you end up with cells that are not able to be recognized by the immune system, and therefore just allowed to grow, right? So as it continues, the cells start to play a different role. And this is something I want to emphasize on the lecture today, is that just because you identify a certain cell in this environment, you have really no idea what the cell is actually doing. The same cell in a different context can be doing very different things. And the familiarity with the cells, with the context, with the cytokines, with the names is really important at this point for radiologists, so that when we talk to our referring physicians, when we review the papers, we actually understand the lingo. I think that's, if nothing else, that is the most important thing you can take away from this lecture. These are all the different cells that are involved. You know, I'm gonna go into each one, but suffice to say that they're all trying to fight the tumor, but are suppressed along the way by a different number of mechanisms. Before we had to worry about cancer, when the things that human beings had to worry about were infections and parasites killing you way before any cancer would kill you, this hierarchy of the immune system developed. So the curious thing is how the body's ability to fight these infections now translates into the body's ability to fight the tumors, right? So we have three main types of adaptive or cellular immunity. You have this type 1, which was developed to fight bacteria that are inside the cell. So basically, to kill the bacteria, the body has to eliminate that cell. So once the cells recognize the bacteria is inside that host cell, it will do things to that cell to eliminate it. That's type 1. Type 2 is what you have when you get a parasitic inflammation. So that is the body trying to protect the cell from getting the parasite into the cell. So that's a different type of reaction altogether. You're trying to protect the cell from getting infected. You're not trying to destroy the original cell. So you're trying to suppress things, and you're trying to preserve the cell. And that's very important. Now, the type 3 is a more recently described, and it's something that is associated typically with chronic inflammation. So if you have certain infections that are more indolent, like fungal infections, certain viral infections, so the body is now trying to fight these viruses and fungi from entering the cell, but dealing in a more protracted course. When you think about type 1 immunity, there's a very important cytokine, IL-12, activates this pathway. And then the cells try to destroy the other cells using different effectors, but it's very, the ones that I separated here, for you to remember are IL-2, interferon gamma. If you remember that associated with type 1, that's really all you need to remember. Then type 2, it's a completely different set of cytokines. But if you remember, it's IL-4, IL-5, IL-10, these things come up over and over again. So these are once you remember 2 or 3 of them and the different drawers, the different patterns that they fit, you realize how when you translate this into a tumor environment, they actually start to make sense. And the type 3, the Th17s, are basically responsible for this one cytokine, IL-17, which we'll talk in a lot more detail in a second. So this is the ideal scenario, right? So you have the tumor cell, your innate immune system recognize the antigens on the surface. It draws both the innate immunity versus adaptive immunity, i.e. like cellular immunity, and destroys the tumor, and it's all like gone, and the person is cancer free. But why doesn't it happen all the time? So this is a very famous diagram that basically shows you in green the things that are anti-tumor and the things that are inhibiting tumor. And then when you look and you see the IL-12, IL-2, you realize that if the body sees the tumor as a bacteria inside the cell, it does a very good job of getting rid of that tumor. What happens is sometimes the body sees those antigens as something different, as a parasite, right? So you see the cytokines or the chemokines are actually the same, but they are used in a different context. However, the body sees as the same type of reaction. And when you get a type 2 reaction, it doesn't do a good job of eliminating because it actually wants to protect those cells. So this becomes then a much bigger problem when you start to look specifically into the issue of cancer. One thing that I'll also discuss in a little more detail is how the way the cells die contributes to how the immune system will recognize the antigen. So that's also important for us because as in interventional radiology, you're trying to promote cell death to a number of different mechanisms, and it does affect the way the immune system responds to the treatment. I think we all got into radiology because we are fascinated by, and we were just talking to David about this. I mean, we're all fascinated by technology and the ability to diagnose something that clinically you cannot diagnose. I think the immunotherapy provides yet another opportunity for us to do that, where you can do some things for our colleagues that they cannot do themselves. So if we have this tumor in equilibrium, I think it's fascinating for breast cancer how you can have somebody who's treated and goes 10, 15 years without metastasis, and all of a sudden some event happens and the person develops metastatic disease from a tumor that they had 10, 15 years ago. So where are those cells? How are those cells surviving that long? And more importantly, what activates those cells, right? So if we can identify those cells and if we can understand what allows them to escape that immune system that was maintaining them, in balance for so long, then it would be a major contribution to science. And in the realm of interventional radiology, is there a way for us to maybe change that process and make them go the other way from a more, progressive escaping to back to balance? Is there some element of thermal ablation, catheter-based therapy that can modulate this? I wanted to give you just the specific cell names that come up over and over again when you read these papers and when you discuss immunotherapy. There are many, many cells, but there's just a few that are very important when you're trying to discuss this with the oncologist. The first big category of cells is called the cells that present antigen, so the antigen presenting cells, APCs. Those are cells that are immediately recognizing the antigens once the tumor starts to grow, and they are key to prime the T cells for the T cells to then produce the cellular immunity necessary to eliminate the cells, right? So you have the dendritic cells, you have the macrophages, and you have the NK cells, natural killer cells. They are not really APCs, but they're also involved in this immediate response to the tumor. So the macrophage is very important, and I'll expand a little more on it. The T cells, cells that stain, or that have this CD3 marker, they are a vast population of cells. But the ones you have to remember are the CD8s, which are cytotoxic cells, the CD4s, which are helper cells, and these Tregs, which are basically cells that are there to suppress the immune system. So you would wonder, like, why do you need a cell to suppress the immune system? Why do you need something that prevents the immune system from working? It is exactly because we are exposed to a lot of antigens that are actually not bad, right? So if you eat something and that goes from your gut through the portal vein into the liver, if the liver was to recognize everything you ate as an aggressor, it would be in a constant state of hepatitis. So the liver is actually very well developed in its ability to suppress the immune system against any type of like acute response. So these Tregs are T cells that are specifically trying to prevent things from killing other cells. And they play a big role in immunotherapy. So the last category are the granulocytes, cells that are recruited in an inflammation. They release granules to kill other cells, and the neutrophils are the most, the one cell that is typical for them, and in essence also the one that's found in tumors the most. Although eosinophils also are interestingly playing a role in the tumor microenvironment. And we studied neutrophils, and they, in the specific setting of interventional radiology, play an interesting role. So if you remember the dendritic cells, the macrophages, the CD4s, CD8s, and the neutrophils, that's what you need to remember. And I'll give you the context in which they are important for immunotherapy. Knowing that the cells exist, I mean, it is actually not enough, right? So you have to know if the cells exist, where are they, and whether or not they're actually activated. So you can have T cells in the tumor, but if they're not activated, or if they cannot be activated because they're suppressed, then it doesn't really help the patient in any way. So here is a plot for liver cancer, which is my particular focus, the types of cells that exist in a tumor. And you can see, again, that CD4, CD8, T cells in general, and the macrophages are by far and away the most important ones, the ones that exist in greater numbers. The other ones are present, but they are present in such small numbers that they actually don't play a huge role when you're trying to modulate it. They play an enormous role in the body's immunity, but when you try to give a drug to modulate the response, if the presence of those cells is limited, then the drug's not going to work. And this is a plot of the spatial distribution of the cells, right? So where are those cells? So HL is for healthy liver, HCC is for the tumor and the areas adjacent to the tumor. And then you can see that, very interestingly, the tumor and the margin of the tumor have a very similar profile, almost identical. And the healthy liver has a lot less of these T cells and a lot less of the macrophages. And that's why the T cells are important. I mean, they are the #1 cells in the tumor. So if you want to try and give some medication that will work, it has to affect the T cells. This is the other concept, which is the activation. So that's a challenge for us, I think, in imaging, because you can say, okay, I'm gonna go look for the T cells in the tumor, but for us as imagers, I mean, imagine how difficult it can be to try to figure out if the cell is activated or not, right? So I think that will always be a challenge for imagers. But the one thing that we can do is try to measure the consequences of what's activated and the effectors that are being released onto the stroma of the tumor. So if you think about the scaffolding of the tumor, if those things are acting on that scaffolding, and they are, then maybe we can measure the effects that it has on the scaffolding. If we can quantify that, and now we're getting much better at quantifying things with technology, and looking at texture, looking at stiffness, then maybe we can quantify it that way, and we don't actually have to see each individual cell. And this is also for you guys to understand the importance of the macrophages and individual cells in the tumor microenvironment. So we went from understanding the greater categories of tumor immunity to looking at each individual cell, then looking the activation of these cells, and then the cytokines that are involved. So those are the important like components of the lingo that they use. So now we can go into a little more of the clinical aspect of it. The checkpoint inhibitors have brought, since 2010, a revolution to cancer treatment. And the two that are, they were approved by the FDA at that time and that have shown the greatest amount of success in the clinic are the anti-CTLA-4 and PD-L1 and PD-L1. Now, one thing to remember, which is I think shows very well the diagram, is that they are actually very different locations. They act CTLA-4 acts between the dendritic cells and the T cells. And now it's important to go back. So the dendritic cells are trying to present the antigens. So this is preventing activation of T cells by decreasing antigen presentation. So we're trying to inhibit that with the anti-CTLA-4s. And the PD-L1 is direct contact between the T cells and the tumors. So that is the tumor trying to evade the immune system. One is something innate, trying to prevent activation of the T cell immunity, and the other one is actually an interaction between tumor cell and the T cells, and that has some important clinical consequences. These are the most common cancers that are treated with immunotherapy. So obviously number one was melanoma. That's the perfect cancer for immunotherapy because the melanomas tend to be highly immunogenic, but also shown great activity in lung cancer, kidney cancer, bladder cancer, lymphomas. And this graph shows why immunotherapy has been such a paradigm shift, is because not only it responds like chemotherapy that has an initial response, but the response is sustained. Okay, that's the biggest difference that we have compared to just regular chemotherapy. Not only the patient gets better initially, but if they do get better, they do better over a long period of time, as opposed to standard chemotherapy that has, if you get a clinical trial that shows response with improvement in survival for 3 months, it's already immediately approved. It's a great achievement if you can prolong somebody's life for 3 months with chemotherapy. These, we're talking about years. That's why it has been such a dramatic interest in immunotherapy over standard cytotoxic chemotherapy. So as radiologists, we are interested in identifying the effects of immunotherapy, both the beneficial ones as well as the complications. What are the specific complications? And can we screen patients for our colleagues? So as most of you are familiar with, this is standard RECIST criteria, just tells you, the red are the tumors. So if the tumor is gone, you don't see it on the CT or an MR, then you call it a CR, complete response. If there's a reduction in size, then you call it a partial response. If it doesn't change, it's stable. And if it gets bigger, it's progression. It's as simple as that. It's a very simple paradigm, right? However, when you're looking at immunotherapy, those rules don't apply. They apply most of the time, but they are often wrong. And the main reason why they are wrong is because at the outset of the treatment, if the tumor is immunogenic, the immune response elicited by the therapy is such that the tumor actually will grow, right? So if you image the patient a few weeks after the start of these immunotherapies and the tumor is bigger, by RECIST criteria is disease progression, and the patient will typically get taken off the treatment, go to a different, treatment or trial. But it's now obvious that there's a subset of these populations that actually do get better. So it is, if nothing else, the most important thing is to be aware of this phenomenon. So when you look at these patients on immunotherapy and the tumors did get large, you raise the possibility of pseudo-progression. And the way to deal with this is basically, although we do sometimes biopsy, most of the times all you have to do is wait till the next round of imaging and the tumors will get smaller. So that basically establishes this paradigm of pseudo-progression. This is to show you the magnitude of this problem. So, after all these different clinical trials with immunotherapy, you can see this additional. That means patients that were thought to be progressing and taken off the trials, they realized that those were not progression. Those are actually responses that were put back into the trial. So it happens about 10% of the patients, 5 to 10%. And so 1 out of 10 can have this phenomenon. It's very important to be aware of it. As it relates to objective response, whether the tumors get smaller after you start immunotherapy, it does happen in 15 to 20% of the times. So it's very different from standard chemotherapy. Standard chemotherapy, you tend to have a larger magnitude of response. Tumors get smaller, but the tumors will grow back again. Usually the second follow-up, 3 months, 6 months, the tumors are larger. Immunotherapy is a completely different paradigm. Tumors can get bigger at the outset and then smaller, or they're stable or the same size, but that is sustained. So it just works differently. And if we're aware of those differences, I think it makes a huge difference when it comes time to report the case. The specific complications that are associated with it, the most common one is this hypophysitis. Is basically patients that are melanoma patients that are on ipilimumab. They develop hypopituitarism, and then we get an MRI and you show the pituitary gland is actually larger. So that clinches the diagnosis 10% of the time. This pneumonitis, particularly ominous. It's not very frequent, but if it does happen, it's life-threatening. And this for PD-1 and PD-L1 inhibitors for patients with lung cancer. As you can see, though these therapies all release the immune system in some way or form, depending on where they do it. So what they do it at the dendritic cell level, or if they do it at the tumor cell level, the complications are different, right? So something to be mindful of. And if you find a patient on immunotherapy that has this new onset of mediastinal adenopathy, that's a benign finding. It doesn't mean that the tumor is invading the mediastinum, but it's also something that is seen in 5% of the patients. Lastly, which is something that I think I've encountered on call in IR, actually not infrequently because we're draining all these abscesses, is these drugs, if they work, now if the patient doesn't respond, they don't have these issues, but if they do respond, they can have a dramatic effect on the colon. And they have this very severe colitis. And according to the surgeons, it's almost impossible for them to operate on them because they almost liquefy the colon. Because if you think about all the immune cells that are just layered throughout the entire colon, if you activate all of that at once, the kind of dramatic effect it can have on the colonic tissue, you're basically like necrosing your entire colon. It doesn't happen very often, but can be pretty dramatic. This is the sort of basic key concept of how we can screen patients, monitor patients as imagers. As I was just telling you before, the infiltration of the cells into the tumor is key for the medication to work. So some tumors are just inherently filled with these cells like melanoma. In those patients, the likelihood that your therapy will succeed is much greater than these cold tumors that have very few immune cells. It's very difficult to draw the immune cells into the tumor. You know, we like to believe that in IR, that we have tools to maybe promote that, but the reality is it's very difficult. And therefore, from the outset, if you can screen the ones that have this pattern from the ones that don't have this pattern, you can select patients and spare the ones that don't have the pattern, the cost and toxicity of the drugs. These are molecular imaging really important landmarks where basically antibodies against the CD3s or the CD8s, so CD8's a subset of CD3, were linked to an isotope, and then you can do a molecular imaging study, PET, and the hope is that we can quantify. As you can see, there's a lot of just physiologic uptake in the liver, but the tumor is here. And if you can measure the difference in uptake, then not only could you screen the patients, but you can also understand whether or not it's, you know, the medication is working. And this is for CD8s. So CD8 is a like prima donna in immunotherapy because those are cells that are directly cytotoxic. Once they are in the tumor, they don't need anything else to kill the tumor cells. And again, like I was showing you, some of these medications work at releasing immediately those T cells from the suppressor effects of the tumor cells. So if you have the CD8s and they're activated, you're killing the tumor and works well. So CD3s, you're trying to measure the entire population. CD8s, you're trying to measure the specific type of population that you're interested in. They're both useful. And research continues into trying to bring this, some of these techniques into the clinic. But there's some philosophical, if you think about the issue of using antibodies. So basically using an antibody against the T cells, and how does that affect the actual, you know, number and function of those cells? It's unknown. So it's one of the challenges to be overcome before bringing this to clinic, is to prove that if you give these antibodies, that you're not going to suppress the person's ability to fight the tumor. So some of the clinical work, preclinical work now has been done into exactly that, proving those concepts. And this is a very recent paper that says that basically, if you block CD8 with the PET tracers, it doesn't really change their ability to activate, but it might push them one way or another into the different contexts. So obviously, it's very complex. This is a study that we did with a small cohort of patients, like a case series at our place, where we did MRIs and MR elastography with this liver cancers, looking at the stiffness before they were like put on immunotherapy and looking at the outcome. And interestingly enough, I mean, the tumors that were stiffer for the, you know, the immunotherapy showed longer time to progression. Why that is, we can speculate, but typically if you have recruitment of cells and if you're like a lot of inflammation, that will make the tumor like stiffer. But it's a particular area of interest to me, and using animal models, we're trying to figure out exactly what the pathological or histological translation of that is. And finally, my research is in liver cancer, specifically in HCC in a rat model. And we know that these immunotherapies, although it's not on the list that I showed you, it's because all these drugs have been tested in all these different tumors, trying to find the ones that actually do work. And the Checkmate 40 trial shows that PD-1 inhibitors have activity in HCC and are safe. So can IR play a role in making these responses better? The idea is to understand how we kill the cells with embolization, chemoembolization, radioembolization. And if we understand that, maybe we understand what type of immune response we are precipitating. one of the biggest challenges for IR is that when you do these procedures, you tend to cause a fair amount of hypoxia. And hypoxia is known not to be favorable when you try to get rid of the tumor using immunotherapy. It brings in all these different mechanisms or in different cells that suppress the immune system. So that is one of the current challenges to be overcome in IR is how much hypoxia are we causing? Can we change the amount of hypoxia we cause by changing either the agent that we use, the dosage that we use, and by causing less hypoxia, which is my hypothesis, by causing less hypoxia, can we be more effective in combination therapy with immunotherapy? So we use this rat model that you guys see here. It's basically very similar to human. This tumor is inoculated into the liver and allowed to grow for 2 to 3 weeks. Then we go in a catheter here into the hepatic artery of the rat, and then we deliver the particles inside the hepatic artery. Although, you know, you think it's very difficult. I mean, it's not the easiest thing to do, but it's actually not as difficult as one may think, putting the catheter in the hepatic artery in a rat. Then once we treated these tumors, we digested the tumors, and we use flow cytometry to quantify the different cell populations that were present in the tumors after the embolization. These are the tumors. So you can see that the treatment, you know, embolization is pretty effective for these rat tumors, where you have the greater percent of the tumor being destroyed by the treatment. And then we're quantifying with software how much of it is clearly necrotic and how much of it is not. The question is, necrosis is more immunogenic than apoptosis. So if we are very apoptotic, then we're probably not eliciting the same immune response. The results showed, which was surprising to us, that a specific type of population that I showed you on the very first slide, which is the type 3 response, was the population that we saw to be increased in the particular context of embolization, these Th17 cells. And I'll tell you a little bit about the Th17 in a second, but it's also important to know that the other cells were not greatly affected in number. So we didn't see more CD4s or CD8s or Tregs before or after embolization. We did see more of these cells in the spleen, the Th17, which shows you that not only that they have a local effect, there's also a systemic effect. And most of the papers, if you look at the papers published on embolization and the effect on the immune system, they do, which is the easiest and most straightforward way of measuring it, which is getting blood. You know, you do an embolization, and then as soon as the patient is on the table, you take some blood, and then you go and measure, you know, those cells in the blood and subsequent time points. And although it does provide some clues as to what's happening, it really doesn't tell you about the context in the tumor, which is really what you need to know. You know, there's different cytokines and the different growth factors. They could have very dramatically different effects. The cells can be doing one thing or a completely different thing. So you do need tissue, and you do need either immunohistochemistry, flow cytometry, or other way of not only quantifying the cells, but whether or not they're activated. So the Th17 cells, like I said earlier, are cells that are typically seen in chronic inflammation, autoimmune diseases, and they secrete this cytokine called IL-17. And IL-17 is known to attract neutrophils. So then you can see how these things kind of all fit together. So not only now you understand that it's a type 3 immunity, but it's IL-17 is involved, and the result is the neutrophils coming and trying to get rid of things that are around the tumor. So they will be present, obviously, in the periphery of these tumors. Because the cytokines have this ability to, depending on these other contexts, do very different things, we needed to know if the particular, you know, issue in embolization, whether or not the IL-17 had an anti-tumor or a pro-tumor effect. The way we went about trying to prove or disprove that is in vitro, was to creating an environment that slightly mimics embolization environment with low oxygen, low nutrients, and putting the IL-17 in there with our cells. And what we saw is that there's a decreased migration of the tumor cells, which could, you know, suggest that this IL-17 after embolization could be anti-tumor, but clearly more research needs to be done in this area. So with that, I'd like to conclude the presentation. These are the people that make this possible. These are all the researchers in the lab that do all the animal work, that do all the processing of the tumors, that they do the flow cytometry, all the really hard work is being done by them. And I'm very grateful to have a wonderful team, without which none of this would have happened and we wouldn't have been funded. So again, it's a great honor for me to be here, a pleasure. And if you have any questions, please feel free.